All right, Dr. Gordon, over to you. Welcome, everyone.
Thank you, Sam. Welcome and good evening, colleagues, presenters, Professor Michael Boyne, Dr. Mike Mills, Team Rivis, Debbie and Maurice, members of the technical team and the AGPJ Secretariat. Good evening and welcome to another webinar hosted by the Association of General Practitioners in collaboration with Rivis Pharmaceutical. The title of this evening's webinar is The Forgotten Complication of Diabetes and Its Management. I'm Dr. Donald Gordon, President of the Association of General Practitioners of Jamaica. It is my pleasure to welcome you to this evening's webinar, where the speakers will take an in-depth look at non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, the forgotten complications of diabetes. Throughout the presentation, we'll see non-alcoholic fatty liver disease and non-alcoholic steatohepatitis and its emergence as an important complication of diabetes and its relationship to obesity and the metabolic syndrome. The first half of the presentation will be done by Professor Michael Boyne, who will take us on the journey to awaken our consciousness on the importance and significance of these conditions. The second half of the webinar will focus on the management of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, and this will be done by Dr. Mike Mills. During these two presentations, I'm sure a number of emerging facts will come to light as the topic suggests it has been a forgotten complication of diabetes. The association is pleased to collaborate with Rivis Pharmaceutical in sponsoring this CME event to reawaken our consciousness to a disorder which is gaining increasing traction as a leading cause of liver disease and also an independent risk factor for cardiovascular disease. The association is pleased that Rivis Pharmaceutical chose the AGPJ to co-partner with them in this evening's webinar. We hope you, our colleagues, will gain knowledge and insight into the emerging importance of these disorders and employ more focus and emphasis on diagnosing and treating them when we see patients who are at high risk for these conditions. I'll now hand you over to Debbie, who will give the sponsors presentation. Could you please go ahead and do this sponsors presentation, Debbie?
Please. Good evening, everyone. Maurice, please nod if you're hearing me. Okay, great. After that long welcome by Dr. Gordon, I am really just supposed to be saying welcome from Rivis Pharma, Dr. Gordon. Maurice will do sometime later in the evening the spotlight presentation for Rivis Pharma. So I just want to say that I'm paying close attention to the number of participants, and I'm really grateful, especially to our presenters, for your time this evening, and I know it will be a fruitful CME for everyone in attendance. Thank you so much, and I can't wait to speak to everyone one-on-one to see what comes out of this CME. Thank you very much.
Thank you very much, Debbie. We'll go into our first presentation, which is going to be done by Professor Michael Boyne. By way of introduction, Professor Boyne is a professor of endocrinology and metabolism in the Department of Medicine, the University of the West Indies, and an honorary consultant at the University Hospital of the West Indies. He received a BSc honors in biochemistry and his medical degree, MBBS, from the University of the West Indies. After his residency in internal medicine at the University of Virginia, he completed a clinical research fellowship in endocrinology, diabetes, and metabolism at the Johns Hopkins University School of Medicine. He was board certified in internal medicine and endocrinology, diabetes, and metabolism. He is a fellow of the Royal Colleges of Physicians of Canada, Edinburgh, and London. His research interests include the roles of hormonal cortisol and adipokines and nutritional factors in early life and the development of the metabolic syndrome. He is a member of several associations, including the Endocrine Society, Developmental Origins of Health and Disease, Caribbean Endocrine Society, and the Association of Consultant Physicians of Jamaica. Dr. Boyne, Prof. Boyne, over to you, sir.
So, thank you. You're way too kind, Dr. Gordon, in your remarks. And I just want to also thank Rivis for the invitation to come and speak, and also to acknowledge my colleague and friend, Mike Mills. And I hope that between the two of us, we'll do justice to this topic. So as was mentioned, my title is non-alcoholic fatty liver disease / MSALD, the new name, which we'll come to in a little while, as a forgotten complication of diabetes, is a little bit facetious, because we say, I said forgotten, but it's not that it's truly forgotten. A lot of people just don't recognize it as a complication of diabetes. But we'll get more into that. So I do have some disclosures. In the past or present, I've received whether travel grants or honorarium from Eli Lilly Doctorates Labs and Rivis. Just because of that, I'm going to mention one or two products in this presentation. Okay, all right, let me see if I can advance. So I was at a meeting last week and I saw this quotation and I had to take it down. That knowledge is power, information is power. The secret in our hoarding of knowledge or information may be an act of tyranny, camouflaged as humility. Well, today we want to share knowledge. So what little I know, I'm going to share with you during this time period. But this is the purpose of us as we all try to achieve our main goal of taking care of patients effectively. So I have a few objectives. I wanted to speak about the changing landscape of diabetic complications, and then a little bit of a flashback to talk about the role of insulin resistance and inflamed ectopic fat in type 2 diabetes, because that's going to segue into the aspect of fatty liver. I'm going to speak a little bit about some of the work that we've also done on fatty liver here in Jamaica. And then we're going to speak about the role of diabetes in causing fatty liver or hepatic steatosis, which is actually my preferred term. Then we're going to speak a bit about screening in diabetic patients. However, some of the more technical aspects of that I'm leaving for Dr. Mills in his presentation. And I'm going to speak about treatment options, wearing my endocrinology hat. And I'm sure that afterwards, when Mike comes, he'll also be speaking about it in his gastroenterology hat. So that way we'll cover both things. And then if we have time, we'll also have a few comments about the role of TZDs in another complication, not necessarily directly connected to fatty liver, but in terms of CNS neurological changes. So just as a way of introduction, I just wanted to tell you about a diabetic secretary who I saw maybe about 20 years ago who had abnormal liver function tests. So she was 54, she had type 2 diabetes, hypertension, and arthritis in her knee. At the time, she was taking metformin and glycoside, lisinopril, and atorvastatin. You know, sounds like a lot of our patients, right? And her doctor had done LFTs because she was on a statin. That's the reason why he did the LFTs, even though I didn't quite agree with that, but he did it. And the LFTs were abnormal. And when I saw her, she was a bit overweight by her BMI. Her blood pressure was 128/76, so not too bad. But when you look at her metabolic numbers, her A1C was elevated at 8.7. Her LDL cholesterol still was not at target at 3.8. Her triglycerides were also elevated at 2.6 millimoles per liter. And her ALT and AST were elevated about 2 to 3 times the upper limit of normal. And coincidentally, she also had an ultrasound done because there was an investigation for gallstones, and there was none, but they did show fatty liver. But the question he asked me is that, should we stop the atorvastatin? Because he was saying the liver function test abnormalities were due to the statin, or he was wondered or worried about that. And I'm sure some of you may have had this scenario occur before. You may have even asked the same question yourself, and afterwards you'll see through the presentation whether it's true or not. So let's do a little bit of background. Just I presume you know a lot, but I'm just making sure we're all on the same page. So old news, everybody knows that diabetes is getting worse. And these are some more up-to-date global age prevalence data on type 1 and type 2 diabetes. Both are rising, but type 2 much more precipitously than type 1. And as you can also see, that even though the global rate is approaching 10%, here in Jamaica and the Caribbean, we've already long blown past 10%, right? So data which is now 6 years old shows that here in Jamaica, the rate was 12%. And that's very true across nearly the whole Caribbean. So we have very high rates. Also, when you look at it as an aging factor, diabetes gets more common as we get older. And by the time you reach 74 years of age, the Caribbean and Latin America, let me see if I'm trying to see if I have a little pointer here. Let me just put it as a pointer here. So by the time you reach age 74, the Caribbean and Latin America, they were estimating that about nearly 30% of people would have diabetes. But I can tell you in the 2018 data for the National Lifestyle Study here in Jamaica, we were already 42% of people over the age of 74. So everybody knows that diabetes is very, very common. Now, if you look at why people die from diabetes and you put on a historical lens, if you go back in time over 100 years ago, before any pharmacological discovery for the treatment of diabetes, if you had diabetes, you would die in a diabetic coma. Your median survival time was 1 year after diagnosis, after which you die in diabetic ketoacidosis. So it was almost uniformly fatal. Then came the miracle of insulin somewhere around in 1922, and you can see the rates of diabetic coma plunged, and to this day are still very low. So they solved one problem. They prevent them from dying within 1 year. They're living longer, and because they're living longer, they now had the chance to develop cardiovascular and renal complications, and that's the common reason why persons with diabetes will die: cardiovascular and renal complications. And we'll throw in, when I say cardiovascular, I'm also including stroke. So as we solved one problem, immediate death, we had a more chronic emergence of complications because they were just living longer. Now, if you look at some of the data worldwide, mortality rates in diabetic complications are actually declining. When you look at things such as CKD, and when you look at all-cause mortality, and you also look at cardiovascular mortality, because we're also getting better in treating individuals who have cardiovascular disease. We have a plethora of interventions nowadays. We can salvage many people with dialysis and transplant for renal complications. So actually the proportion of persons dying from these complications is declining. But now that they are living longer, we're seeing other complications start to emerge. So I don't need to tell this group, but cancer is on the rise. And cancer has as a strong risk factor diabetes as well as obesity. And so you can imagine that while we are salvaging people from cardiorenal mortality, we're also getting the emergence of other complications because they're living longer. So this slide is also to try to show you that you have traditional risk complications of diabetes, such as heart disease, heart failure. Well, actually, heart failure is increasing, but that's another story. Stroke and peripheral vascular disease. And we know for the microvascular complications, you have renal, retinal, and neuropathy. But because we're doing better, we're now seeing emergence in other types of diseases. So we're seeing now that cancer is emerging, even novel infections, and while we're here this evening, liver disease. But also, persons are living longer and they're having more disability. And the disability is because withering and wasting of muscle and bone, osteosarcopenia. We're seeing more dementia and more mood disorders. So again, we are doing better in certain areas, but things are emerging in other areas. So the spectrum is changing. Worldwide, there are improvements in the classical complications of diabetes, as we just mentioned, but we're seeing an increase in prevalence of the disease itself and non-traditional risk factors, inclusive of cancer, dementia, and liver disease. Now, I know that I'm starting to get a little bit long in the tooth because this slide I put at the top of it, 2000. This slide was made in the year 2000. So that's nearly 25 years ago. And at that time, with what we had for diabetes treatments, basically we recommended give someone an insulin sensitizer because they have a problem with insulin resistance, and give someone an insulin secretagogue. So something that stimulates the pancreas to improve early phase insulin release, and that'll bring down your postprandial glucose and therefore help to improve complications, and give them an insulin sensitizer, which is going to work at the liver also, improving hepatic glucose production, improve glucose uptake, and that lowers fasting plasma glucose. Overall, you get a lower in your A1C and therefore improvements in your complications. And that pattern to this day, actually, even though we have multiple other drugs, still remains true. And just as a reminder, as I try to tell people how persons develop diabetes, we can plot everyone's sensitivity for insulin. So over here on this slide, you're very insulin sensitive. Over here, you're very insulin resistant. Over here, you have little production of insulin, and up here, you have a lot of production of insulin. And let's say I'm going to pick on somebody in the audience like Maurice. So let's say I measure Maurice's insulin sensitivity and his insulin production, and I put him right here on the 25th centile line. But, Maurice is doing very well. He's gaining wealth. He puts on some weight. And because he's put on some weight, he becomes a bit more insulin resistant. But he produces a little bit more insulin, and he manages to stay on his curve and remain in normal glucose tolerance. But if he has a sick beta cell, Maurice is eventually going to fall off the curve, develop impaired glucose tolerance or prediabetes. And if it falls even further off because of impaired insulin secretion, he's going to reach into the diabetic range. And so for a long time, what we have said is to improve persons with diabetes is that you want to either make them more insulin sensitive or you want to make them produce more insulin, just like what you showed in the slide. Now, here's some data from Jamaicans. Do Jamaicans have the same sort of thing? Yeah, we do. So this is Spanish Town people that we reported on 20 years ago, that as they developed glucose intolerance, it was driven a lot by beta cell failure. So here's their insulin sensitivity over here. Here's their insulin secretion over here. And here are the people who over 4 years did not progress in terms of their glucose status. But here are the ones who did progress. You could see they just fell dramatically downwards, driven more by a pancreatic problem rather than insulin resistance problem. Both are there, but it was more beta cell function. So we've always been speaking about how can we preserve beta cell function? And the ADOPT trial years ago said you can slow down the deterioration of the beta cell if you use a thiazolidinedione. And in the ADOPT study, rosiglitazone was used. And as you can see, over time, the persons who had better preservation of their beta cells was in the rosiglitazone group. They were able to stay on monotherapy, or they're more stable, while unfortunately persons were on a sulfonylurea-like glyburide, they deteriorated much more. So we know that we can preserve beta cell function using something like rosiglitazone, which we don't have anymore. We do have other drugs that help to preserve beta cell function, such as pioglitazone. We also have GLP-1 receptor agonists, such as liraglutide, and we have SGLT2 inhibitors, such as dapagliflozin. And these drugs do help to preserve beta cells. And that's one of the things that we like, because it helps to prevent the progression of diabetes as things get worse. And one of the things that drives the progression of diabetes, and don't worry, we get into fatty liver, but I just have to lay the groundwork, is also the aspect of fat, because we're going to be speaking a lot about fat. And we know that our adipose tissue is our largest endocrine organ. It produces a huge number of metabolically active molecules as well as hormones. And we are especially interested in adiponectin, which we've also done some work here in Jamaica. And we've also shown that adiponectin, which emerges from adipose tissue, especially when that person is insulin resistant, helps to predict the development of glucose intolerance. And we're coming back to adiponectin a little bit later. So if you have a lot of fat and the fat is insulin resistant, you're going to have problems with glucose management, and you're also going to have problems with metabolic dysmetabolism in general, the metabolic syndrome. And I've been showing this slide also here for more than 20 years. Here's a CT scan at around the level of L1. And you can see these individuals here who are not diabetic. They did not have much fat, which is all the white stuff, marbling in the inside of their abdomen. But persons who had type 2 diabetes had a lot more visceral adipose tissue, and they were also more insulin resistant. But as we like to say, where is the fat? Fat in different depots has different functions. So if you have fat underneath the subcutaneous compartment, in the subcutaneous compartment, around the face, on the back, on the thighs, in those areas, it is metabolically inert. However, if you have fat in ectopic sites, such as the abdomen, the liver, and the muscle, then you're going to get into problems. And guess what? If you have fat in one depot, ectopic depot, you're probably going to have it in the others. So if you have intra-abdominal fat, you probably have some hepatic fat, and you probably have some intramuscular fat. So once we see fat is not in the subcutaneous areas, but in the abdomen, we are generally speaking about you have more liver and intramuscular fat that will create a problem. Now, we also have this thing called a fat overflow hypothesis, and we have also produced some data with this here in Jamaica and internationally, that when you put on weight, so take, for example, Christmas is coming, you eat a lot of Christmas cake, you have a lot of sorrel, you're going to have some ham, you're going to have a grand time, and you put on 2 kilograms. Where does that 2 kilograms go? Well, generally speaking, you will start to increase the deposition of fat in the subcutaneous compartment, right? And your cells there will swell from about 30 micrometers to about 100. But then after that, they become overwhelmed. And the fat is going to spill over into other sites, such as in your abdomen, in your liver, in the muscle, in the pancreas. So the fat overflows into these compartments. And one marker of that overflowing of fat is your adiponectin levels. Because if your adiponectin levels are abnormal, that's a sign that you have fat overflow into other areas. And we can move fat around, and one medication that can do that is thiazolidinediones. They tend to move fat from the intra-abdominal, liver, and muscle into the subcutaneous compartment. And that's one of the reasons why you might see persons when they tell you that they use things like pioglitazone or rosiglitazone, that they notice they put on some weight or around their face or on their arms or legs. That can happen in some individuals, and is a matter of redistribution of fat from within the abdomen, within the liver, within the muscle, into subcutaneous depots. So having laid that aspect about diabetes and fat itself, let's think about now some of the consequences of this sort of fat overflow. And the old term, as we used to say, was non-alcoholic fatty liver disease. And persons said they didn't really like that because it brought in various things that did not seem very nice as we say them. So, are we accusing people of being alcoholic when they're not? Are we calling them fat and people are sensitive about that? So the name has changed. But when you look at the global prevalence now of this emerging complication of diabetes, of type 2 diabetes, or fatty liver or hepatic steatosis, as I prefer to say, we'll see that the global prevalence is about 56%, global prevalence. Now, in some more recent data, in a meta-analysis just published in June of this year, globally, we can now see that there are about nearly 500 million persons with diabetes worldwide. But of that, 2/3 of them will have evidence of metabolically associated steatosis in their liver, right? So they're going to have more MASLD. Some people have various ways of saying it. I prefer just to call it MASLD, but basically hepatic steatosis. And as you can see here, that the prevalence has been rising over the last 30 years. So before it was about 50%, and now it's about 2/3 of individuals will have evidence of fatty liver around the world. And many of these are going to have evidence of a more sinister complication where you're now having inflammation with ballooning necrosis and fibrosis, and therefore an advancement towards a more sinister end-stage liver complication that you and I may know also colloquially as cirrhosis of the liver. So persons who have type 2 diabetes have a lot of fatty liver, and some of this can also progress, which is what this slide is trying to show, that persons who tend to have MASLD or hepatic steatosis, more common in persons who are overweight, diabetic, have hypertension, have hypertriglycerides or high triglycerides, low HDL. Quite a lot of those persons can advance over the next 5 years. So within 5 years, anywhere from 25 to 40% of them can advance to steatohepatitis, where on liver biopsy, you can see evidence not just of benign collection of triacylglycerols in the cytoplasm, but you will now see evidence of inflammation, as we said, necrosis, as well as fibrosis. And a small portion of those over time will progress to cirrhosis of the liver. And a smaller percentage over time can even progress to hepatocellular carcinoma, hepatic carcinoma. So once you develop hepatic steatosis, in some people it will be relatively benign, but in others it will produce an inflammatory mix with fibrosis that can lead to more sinister end-stage liver disease, as well as other complications, which we'll come to. And one of the things, as we have in this sort of summary slide, is that if you're diabetic, hypertensive, going through the menopause, which leads to weight gain in the visceral component, weight gain for any reason, just from your lifestyle, as well as certain genes, they can also hasten this progress or delay the progress. So Mike, I don't know if you're going to mention this before, Mike as in Mike Mills, that the classification has been updated in more recent times. So we're throwing away the non-alcoholic fatty liver disease component, and we prefer to say metabolic dysfunction associated steatotic liver disease as MASLD. Now, some people say MAFLD, but Europeans and North Americans tend to use MASLD, and some places of Africa and Asia tend to use MAFLD, but it's still the same thing that we're speaking about. So we'll have these individuals who develop it, mostly diabetic and obese individuals. A portion of them will develop steatohepatitis or MASH. Some persons are going to have alcohol liver disease, especially if they take as much as 60 grams of alcohol per day. And some persons are going to have a combination. If they have both metabolic syndrome, driving hepatic steatosis, as well as they are also having increased alcoholic intake. And so they have that acronym of MET-ALD, right? So they can either, depending on how much alcohol they take, histologically look a little bit more like MASLD or hepatic steatosis, or they can look a little bit more like alcohol-associated liver disease. And of course, you will have some individuals who have other etiologies, whether it's drug-induced or viral, etc. And then there'll be some which will also be unknown, cryptogenic, as the description is called. So we've said a little bit about this already, but I want to give a little bit more detail. How do people actually develop the hepatic steatosis in type 2 diabetes? So many persons with type 2 diabetes will have, as part of their lifestyle, unfortunately, excessive amount of saturated fat, simple sugars, and physical inactivity. And these will provide fatty acids as well as substrates for the development of hepatic triglycerides. So if you go back to your biochemistry days, if you're having a flux of fatty acids and glucose and fructose converted to glucose, you're going to have a rise in acetyl-CoA within the liver, and that is going to help to overflow into the production of lipogenesis or fat synthesis. You're also going to get a lot of fatty acids coming from within, not just from your diet, but from within your body, from your adipose tissue. So if you have inflamed or insulin-resistant large depots of fat, you're going to have more free fatty acids fluxing towards the liver to be used to form, again, fat within the liver. And you're also going to have a decrease in adiponectin, which is going to stimulate the process. And with a rise in triglycerides in your liver, the liver is going to develop hepatic insulin resistance, especially in the face of adiponectin. And when this occurs, when the liver, now full with fat, also becomes insulin resistant, it's going to increase the production of glucose, it's going to export more triglycerides, and you're going to see that as a rise in also your VLDL, triglycerides, a decrease in your HDL, and an increase in small, dense LDL particles. And as you can imagine, that's going to be now a sort of atherogenic dyslipidemia. So you're going to get hyperglycemia, you're going to get atherogenic dyslipidemia, and you're also going to get acute phase protein stimulation as well as coagulopathy. And the mixture of inflammation, hyperglycemia, atherogenic dyslipidemia can lead to vascular dysfunction, especially in light of if there is insulin resistance within platelets, as well as insulin deficiency, not enough insulin coming from the pancreas. And all of this will give you this milieu of hepatic steatosis, insulin resistance that we're going to see in liver, fat, muscle, as well as even platelets. So this now becomes the perfect storm. And as you can imagine, all of this is not only just bad for you in general of hyperglycemia and fatty liver and the liver consequences, but also cardiovascular risk is going to be dramatically increased. Now, there are people have been looking for a while. How can we find simple markers of fatty liver? Is there something we can just measure in the blood that might signify fatty liver? And persons have been playing around with adiponectin as well as a hepatokine called fetuin A. And some of the studies were also very promising that if you have low levels of adiponectin and high levels of fetuin A, which comes from the liver when it's filled with fat, these are good markers for fatty liver. So is this a nice way that we can screen for fatty liver? So bear that in mind, because I'm going to come back to it a little bit. Also, something that we know is that there's a dose-dependent association of free fatty acids with diabetes development in persons with hepatic steatosis. So as your free fatty acid levels rise in that individual, we also see a progression towards insulin resistance and over type 2 diabetes. Also, if you're already diabetic and your A1C is not well controlled, the severity of your hepatic steatosis is going to be increased, which you kind of already assumed from our conversations before. So basically, we're saying there's this interlink between the two of them. You have type 2 diabetes, you can get NAFL. Sorry, I shouldn't say NAFL, hepatic steatosis. If you have hepatic steatosis, you're going to get increased risk of type 2 diabetes. And so it's a continuous feedback circle. And therefore, when we're breaking the link, you'd want to break the link for both of them. I want to speak a little bit more about complications of fatty liver. So we spoke about that. Here you have this insulin-resistant liver, and it's full of fat. And it's full of fat because of many hits that have occurred. It's our diet, it's insulin resistance in different tissue organs, it's lipotoxicity with lots of free fatty acids coming down. It's also even our gut microbiome, and I just don't have the time to speak about that too, but that also too has a role. But all of that is going to help to promote fat in the liver and the production of a low-grade chronic inflammation. And that chronic inflammatory milieu throughout the body over time will lead to fibrosis within the liver and then cirrhosis, as well as also hepatomas, but also is going to increase the risk for atherosclerosis, as we just mentioned. So coronary artery disease is going to be changed again or increased. The kidneys are going to be at greater risk. So chronic kidney disease, CKD, is going to be affected, as well as an increased risk of cancer. So there's a 15% increased risk of cancer, up to a 2-fold increased risk of cancer in persons who have chronic hepatic steatosis causing low-grade inflammation. So once you also know someone has hepatic steatosis, you got to know what's going on with their kidney, what's going on with their heart, and they are at risk for cancer, and therefore they should be up to date with their cancer screening. We do know that some genes can influence the consequences of steatosis. So take, for example, here you have a liver full of fat right here. And if you happen to have these variants, PNPLA3 or MBOT7 variant, etc., these can help to increase the risk for development of cirrhosis. Ironically, those same variants actually seem to protect against the development of cardiovascular disease. So one genetic milieu promotes more liver disease as a complication of hepatic steatosis, and those same variants might protect you against cardiovascular disease. However, if you have these other variants, such as the MARC1 variant or the hydroxysteroid dehydrogenase 17B13 variant, they themselves are more protective against the development of liver disease, liver complications, but they do worsen the the chance of developing cardiovascular disease. So this is part of the reason why we see some persons, when they develop fatty liver, some are going to go down much more of a cardiovascular complication, while some others are going to go a little bit more along hepatic complication of cirrhosis and hepatoma. Now, I mentioned that we had looked at some aspect of hepatic steatosis here in Jamaica, and we actually were looking at this as in individuals who had actually survived malnutrition when they were younger. And we now had them as older individuals, and we had done CT scans on them looking for not only their fat distribution, but also what was the degree of fatty liver. And these are non-obese people. And one thing I'd like to remind in the group that while obesity and diabetes is a risk factor, about 10 to 20% of individuals who are diabetic and about 10 to 20% persons who have hepatic steatosis do not have an elevated BMI. They're in the normal range. However, if you look at their percentage body fat is higher and is redistributed in the ectopic sites. But we are also interested in some of the markers of fatty liver. And we found that, we didn't find adiponectin and phenytoin A that we were so interested as markers in our population. They unfortunately were not associated with liver fat. So the search is still on what is a nice, effective blood marker of liver fat. We did find, though, that the persons who were also malnourished in early life tended to have more liver fat in later life. And this is part of a body of work that your cardiometabolic risk, including your liver hepatic steatosis, is much more increased if you had poor nutrition, undernutrition, when you were in early life, from fetus onward to early childhood. And so some of this work here is with in collaboration with Debbie Thompson. And we also show that if you try to fatten up these kids early in life to get over their undernourished state, it led to greater risk of fatty liver in later life. So bad if you are malnourished when you're younger, even worse if you fed them too quickly, these individuals had much more fat in later life. And this is what we were seeing in persons who had non-obese fatty liver. So I want to mention a few things about management in the time that we have. And of course, some of this is going to overlap with Mike when Mike Mills comes on, and he will give you an even better presentation, right? But here's just some of the ways that we kind of look at fatty liver. And I'm using here the American Association of the College of Endocrinology, the ACE guidelines, so to speak. And there's another set of guidelines I'm going to show you towards the end. But in the ACE guidelines, one of the things they said, is the person at risk for fatty liver? Do they have prediabetes or type 2 diabetes? Are they obese, have metabolic syndrome, or you just happen to see hepatic steatosis on ultrasound or CT scanning, or they have some transaminase elevations, mild transaminase elevations? These persons are at high risk for fatty liver. You may want to rule out some secondary causes depending on the history and the physical exam that you found. And then you would like to prevent them from having cirrhosis and prevent them from having cardiovascular risk factors. I'd also even like to say prevent them from having cancer, but we don't have much data for preventing cancer. But that's part of, at least for early detection and screening. During this time, you want to manage them holistically. Manage their weight, manage their glucose, manage their blood pressure, manage their lipids. And you want to risk stratify them to see, are they at risk of hepatic complications, which Mike is going to speak a lot more about. Are they low risk or high risk, or are they indeterminate in their risks? Now, doing risk stratification can be done by a FIB-4 index, which Dr. Mills is going to speak about. But let's just say that we're going to utilize a calculator. You can have it on an app on your phone, which is what I have, and you can calculate based on their age and transaminases and platelets, their level of risk. And if persons are low risk, then we just continue managing them, but focus on all aspects of cardiometabolic protection. if they're high risk, they really should be in Mike Mills' hands, right? And if they're indeterminate risk, then they might need more elucidating. And part of the ways of doing this is not only by using the FIB-4 index, but if they're intermediate risk or high risk by the FIB-4, they may need things like hepatic elastography or other modes of testing, but I'm going to leave that for Mike when he's coming up, all right? So, but even though we think about screening, people have been asking the question, should you screen everybody? Is it really feasible given the large numbers of persons that we have? So here are some numbers, and all of us are advocates for screening, right? You know, that's as clinicians, we want to even prevent disease, but there's a little bit of a limitation. So if you take persons who have type 2 diabetes, and we already said that about 2/3 of them will have fatty liver, right? Of which a small number are going to have more fibrosis. And we do FIB-4s on them. You're going to have an sort of elevated FIB-4 in about roughly 40% of them that are going to now need elastography. And of that, they're probably going to statistically find that about 20% of them are going to have increased risk, of which they are now going to need referral to hepatologists like Dr. Mills and any other gastroenterologists who are listening. And when they screen that individual, might need to also have to do biopsies, etc. There's going to be a lot of false positives. So there is the problem that by the way we have screening right now, there is going to be a lot of persons who might need tertiary referral and intervention. And so the need for better screening modalities, and as you said, Fetuin A was not a very good one in our hands, and adiponectin, etc. But we do need better ways of screening so we can be more precise. But let's suppose now we've found that these persons do have fatty liver, right, or hepatic steatosis. What should we do with our diabetic person who has fatty liver? So the general thing is that we'd like to reduce the amount of hepatic steatosis. And we're going to speak a little bit more, but there's lifestyle modification, and so weight loss will be very good. You're going to reduce the fat depots, you're going to reduce the fat insulin resistance. There's some medications that could also be used. We're going to mention some of them. PPAR receptor agonists, incretin receptor agonists, SGLT2s, and thyroid hormone receptor beta agonists. But I'm also going to leave some of this for Mike at the end. These can help in reducing fat. Some of them can help in improving the steatohepatitis, and also delay the development of fibrosis, although many of them cannot be used if cirrhosis has already been developed. So for lifestyle modification, our persons with diabetes, we always want to have them have better lifestyles. And I know you're already talking to them about their meal plans and their physical activity and their sleep and stress reduction and all the things which are necessary for management of their cardiometabolic risk. And you need to do that. You need to intensify it if they have fatty liver. So if they have fatty liver, we really would like to see some weight loss. Some people speak about 5%. Most persons, which would say is more or less the minimum, 10% would be better. And you may even want to consider metabolic or bariatric surgery. So basically, the lifestyle intervention is very similar to what we already have and know from management of diabetes and persons who have high cardiometabolic risk, but you really want to intensify it if they do have fatty liver. I have one slide here that speaks about GLP receptor agonists. So we have from liraglutide to semaglutide. We have tirzepatide. So all of these have been shown, and especially sort of meta-analyses, that they do much better than other medications for diabetes in helping to improve fatty liver. So these agents, because the persons are diabetic, you need to give them something for diabetes control. So what diabetic medications can you use? And certainly GLP-1 receptor agonists have been shown. And they've also been shown to reduce the stage of necrosis and fibrosis. So there is improvement when we use these agents. I'm not going to go into a lot of detail, but certainly these would like to be on the forefront of our minds. They're not, in terms of accessibility, as really accessible in the Caribbean. Part of that also too is financial, because they are also very pricey, but they do help, especially because of weight loss. We do have pioglitazone, and actually pioglitazone was one of the first agents that were out through the block to speak about reduction in the staging of hepatic steatosis. So in this study, which is now almost 20 years old, where pioglitazone was used in persons who had liver biopsy confirmed steatohepatitis. It was a relatively small study, but they randomized people to maximum dose of pioglitazone or placebo, while also maintaining a lower calorie diet. And generally speaking, that persons were, I think I have the wrong one up here, but I think I have the wrong slide here. This is the, here's the slide. Yeah, so that what they found was that inflammation, necrosis, steatosis, and fibrosis were improved in the individuals when they were taking pioglitazone. Improved their blood glucose, which is going to improve their fatty liver stage, but also they saw not just reduction in fat, which is steatosis, but they also saw a reduction in inflammation histologically, ballooning necrosis, as well as fibrosis. They also reduce other things, such as improve their adiponectin, their transaminases were improved, etc. So all of these were improved in the studies, and ever since that time, pioglitazone has been used by many persons if persons have concurrent diabetes and known fatty liver. We didn't have much long-term data, and then maybe about 8 years ago, in this study, again, by Kenneth Kusi, one of the gurus in fatty liver and diabetes, looked at the sort of long-term for persons. I forget what the length of time, I think it was about 3 to 4 years. So these persons who were randomized previously to pioglitazone or placebo, you could see that in the pioglitazone group, there was a 58% reduction in the activity score on liver biopsies, compared to not much change in the persons who were in the placebo group. And actually, half of them actually did have resolution of steatohepatitis. So they did show that in the long term, it's feasible and led to better liver histological improvements. As well as there was reduction in triglycerides, improvements in insulin sensitivity, also improvements of insulin sensitivity in fatty tissue and muscle. So it kind of helped to reverse a lot of the insulin resistance and the consequences of it that were seen before. So the ACE guidelines, as I getting close to wrap it up, what do they recommend? So they recommend that persons should be risk stratified if they have diabetes, and you should do something that's going to help both their diabetes and their liver. So what they recommended was GLP-1 receptor agonists or SGLT2 inhibitors if the person has heart disease, and if they had kidney disease or heart failure, an SGLT2 inhibitor. That's what was recommended. Now, if they did not have cardiorenal complications, they said then you can either consider pioglitazone, GLP-1 receptor agonists, or SGLT2 inhibitors. Of course, you can't use these when they have cirrhosis, but once they're having steatohepatitis, these agents could be used, and there was some evidence for it. There's a little bit of a problem, though. The problem is that many of the studies were relatively small scale, what we call, so they were more like a tier 2 level of clinical trial rather than large scale clinical trials. So we do have a lack of data. There's a paucity of data for large scale clinical trials, and that's what we really need to have also going forward. But in the most recent guideline, so I showed you the ACE guideline. This is the EASLD. So these are the European guidelines, and this is a combined group of the groups that are studying liver, diabetes, and obesity together. And in their recommendations that came out about, I think, in June or July of this year, they are saying if you have steatohepatitis, then you really want to have this sort of thyroid hormone selective thyroid hormone receptor selective medication, resmetirom, which is available in the United States, but is not available in the rest of the world, which has probably the greatest amount of clinical trial data to show improvement in fibrosis scores and improvement in the overall histology of the patients. So that would be the best one to be utilized. Doesn't do as much for the diabetic control for the individuals, however, though. If they have type 2 diabetes, they were recommending GLP-1 receptor agonists, SGLT2 inhibitors. There's good old metformin, and they have insulin if they're reaching to the stage of cirrhosis. Now, you might notice that they don't have pioglitazone in this group. And even though they acknowledge in their summary that pioglitazone has a role, but the studies are not not large-scale clinical trials, which led them to rank it lower than some of the others. So the ACE guideline still has pioglitazone. The more recent EASLD guidelines does not have it there, even though it's a consideration. And so it's going to be interesting to see now, because this is what the Europeans are saying, to also see what the Americans might say later on when they're looking at their guidelines again about this. But I suspect it's also just because there is, to my knowledge, one large-scale trial that is supposed to be ongoing at this point in time. So await more data for pioglitazone, but I certainly do use it. It's readily available and as an option. So here's some unanswered questions and research needs that we don't know. There's still a lot we don't know. What's the true prevalence of advanced fibrosis in type 2 diabetes? We don't really know, to be frank. We have illusions for some data, some observationally, but we don't really know. Does type 2 diabetes independently affect the progression of liver disease? We have some observational data, although it's still not conclusive. There are different diabetes subgroups, and that's another large discussion. Type 2 diabetes can be divided into about 5 different subgroups. And do any of those have a higher risk of progression? Although some of us might believe that the group that has more insulin resistance would have more risk of progression of fibrosis. What's the optimal case finding strategy? We still don't know that as yet. Should we consider ethnicity in biomarker use? I showed you some data that we didn't have that much luck with using some of the biomarkers in our hands, at least. And can they be used to monitor the individual as you treat them? And does screening improve the outcomes? And is it cost effective? So there's a lot more research that can be done in this area. Now, the last thing I just want to say, because I've finished with liver, I told you that we have emerging, we have cancer, we have liver disease, we have dementia, we have frailty. But I did want to mention dementia. Everybody asks me nowadays, why are so many people having dementia? Diabetes is a very strong risk factor, and insulin resistance is a very strong risk factor for dementia. And we're seeing more and more, as we keep our patients alive, more dementia emerging. And as it is right now, pioglitazone is one of the fewer agents that also does reduce the risk. And in this randomized clinical trial, where they took individuals who already had a stroke and were insulin resistant, not flagrant diabetic, but more pre-diabetes with insulin resistance, pioglitazone did reduce the risk by about 25% of new onset stroke, MI, and type 2 diabetes. And there are observational studies that show the protective benefit in dementia. And this is an area that needs to be really more rigorously looked at, because most of what we have is observational data and not hardcore clinical trials data, but look out for it as we also look at dementia in this way. And so my slide, just to kind of stop talking, is that you may have seen a slide like this before. You have a person with type 2 diabetes, they're known to have diabetes. You already have them on metformin and maybe some other treatments, but they may have a complication. If they have heart disease, as what this is trying to say, then you should also be considering a GLP-1 receptor agonist if available, and an SGLT2 inhibitor if they can afford it, because those show very good clinical trial data for improvement of those complications. If they have heart failure, you want an SGLT2 inhibitor. If they have neurological complications, and now I'll also include in this list also liver complications, a GLP-1 receptor agonist or pioglitazone could be considered. And if they have CKD, then an SGLT2 inhibitor or GLP-1 receptor agonist could be considered also. So, so as you think about your patients who have complications, just remember that you can prioritize. Once they develop complications, it becomes a more expensive disease, right? Because we're talking about GLP-1 receptor agonists, we're talking about SGLT2 inhibitors. We're adding a little bit more cost with pioglitazone, even though it's a bit more affordable with various other offerings on the market. But once they develop a complication, it becomes more complicated. And so therefore we want to just avoid it. And so with that in mind, the last slide, and then I don't know if we have time for questions. It's now 7:33, which is about the time for me to stop talking. Basically, what we're just saying is that persons who have diabetes and they're obese, they're very high risk of developing fatty liver. Please remember, though, that about 10 to 20% of them may not be obese. And you may or may not have other evidence of fatty liver, such as on imaging, ultrasound, or CT. Or elevated liver function tests. You may need to then, in those cases, consider secondary causes. Workup can ensue. We're going to hear more from Dr. Mills about using FIB-4 index and liver stiffness or elastography and help to prioritize the individuals. And then they may afterwards now need to be intervened. An intervention is weight loss, both from lifestyle, also bariatric surgery is an option for individuals. You need to optimize their other problems of lipids, blood pressure, etc., because they have high cardiometabolic risk. We can use disease-modifying agents such as GLP-1 receptor agonists, pioglitazone, SGLT2 inhibitors. I'm sure somewhere in the conversations, people are going to ask about vitamin E and also bariatric surgery. And with that, I am going to stop. I had one or two cases that one could look at, but perhaps we could do that at the end. But I'll just stop in case if we have any more direct questions for me to answer. I hope I haven't lost you along the way.
Thanks. We'd like to recognize Prof. for an excellent talk on steatosis and its risk progression to liver, cardiovascular disease, and cancer. There are questions, and I'm sure we can start with some questions and answers.
Hey, Doc. So the first question is, what is a newly diagnosed DMT2 workup and management? RBG's 25.6 and blurred vision on presentation to the physician.
Okay. All right. Some missing data, but anyway. So I mean, so things like age and a few other things might have been useful, but I'm not surprised this person has blurred vision if your random blood glucose is already 25. Now, it is also true when persons have such severe hyperglycemia, still keep in the back of your mind, always keep in the back of your mind, could this person also have type 1 diabetes? Especially if they're young, such as a lack of a family history of diabetes, if there's no other risk factors such as hypertension or dyslipidemia, etc., in the back of your mind, or see there, age 44 female, right? So in the back of your mind, just remember, we still can have type 1 diabetes, almost, quite frequent. I'm not going to say every week, but I can tell you about once a month, I'll diagnose somebody who has real type 1 diabetes, but because they were middle age, etc., people just thought that they were type 2. So that's one thing to consider. And if they're atypical, then you may want to at least do anti-GAD65 antibodies to see whether or not they have type 1 diabetes or a fasting C-peptide level. So that's one thing to consider. But two, once you have that individual now with this hyperglycemia, as well as they're symptomatic, so they don't need any other test to confirm they have diabetes. They don't need an oral glucose tolerance test. They don't need a fasting test. They fulfill one of the criteria for diagnosis. They have a random greater than 11 and they're symptomatic. So you need to start treatment. And in those individuals, then of course, again, what's happening with these individuals? Very symptomatic individuals, I would consider using insulin, at least in the first stage, bring down their blood glucose, and then you can see what they may require afterwards. If they're not terribly symptomatic, I would use combination therapy. I would not use monotherapy in somebody with a 25. And the guidelines also speak to that. So you'd probably get back their A1C, and the A1C will probably be more than 10 on that. And that's convincing evidence that you probably should start dual combination, metformin plus something else. And that something else can be quite variable. You'd also want to know what is their lipid content. You would also want to consider whether or not in this person you want to risk stratify them. And certainly, as in cardiovascular risk stratification, and certainly they need a microalbumin and creatinine to check their renal function. So all of these should be done in this individual. And combination therapy started at the beginning, and combination therapy should at least include metformin. I don't know if I've answered that question for the individual, but I hope that might have been of some use.
Wonderful answer, Doc. See, two more questions here. There was one about what did you advise for the secretary?
Ah, yes, one in the beginning. Yeah, I was wondering if somebody was going to ask me about it. Well, guess what? In this individual, so she has diabetes, which is not well controlled. She has hypertriglyceridemia, and she has everything to suggest, and she even has, in this particular case, ultrasound that suggests fatty liver, and she also had transaminases. We did check for a few other things, because you might remember, even though we're clinicians, you can't just be pivoted. So you may want to check for other causes, other liver disease, and you're going to hear a little bit more from again, Dr. Mills. But in this individual, I thought that it had nothing to do with her statin. And actually, the risk of transaminitis with statins is much lower than people think. But the risk of fatty liver with transaminitis is much higher than people think. And especially with her hypertriglyceridemia, signifying that she probably was having a chronic inflammatory response to her fat. So in this person's case, to be quite frank, I put her on 15 milligrams of pioglitazone, and then I increased her after a month to 30 milligrams. And I can tell you that her transaminases normalized. Her triglycerides also normalized, and her A1C improved, didn't reach less than 7 where I wanted it, but she ended up about 7.7 with her improvement in her A1C. And then she disappeared. So I presume that she's doing well. I presume, but I've not seen her for several years since that time period. So that's what happened to the secretary.
Wonderful. Can HbA1c results greater than 6.5% done in labs in Jamaica be used to diagnose diabetes?
And yeah, there's not a week that goes by that I don't get this question. So yes, if you look at the American and the European guidelines, and they will say that A1Cs of 6.5% can be used to diagnose diabetes, right? if the lab has the standardized assay, right? So if they're using a national glycohemoglobin standardization protocol, that's the technical term. If they are standardizing that, then you can have some reliance that this person might truly be diabetic. Now, not all labs in the Caribbean are using that. And therefore, we have generally not recommended to use that as an only criteria in an asymptomatic individual. So if I have an asymptomatic individual and their A1C is 6.8%, I do not use that alone to make the diagnosis of diabetes. I might combine it with a fasting or an oral glucose tolerance test, but it is suggestive. But I can tell you in my experience, when I've tested up to, maybe up to 2/3 of the individuals with a formal gold standard oral glucose tolerance test, they come back normal or maybe pre-diabetes. Now, one of the things that we also have to know, there are some ethnic differences with A1Cs. And in people of color, we tend to run A1Cs about 0.3% units higher than Caucasian individuals. So one, there's talk about whether or not we need to look at the assay better, or do we need to use ethnic specific cutoffs, which are higher for our Caribbean population. But until there's standardization of the assay, we're not in favor of it. So my suggestion would be do a fasting with the A1C and then make your decision about whether or not the person has diabetes, or an oral glucose tolerance test if their A1C is elevated.
Perfect. Thank you so much, Prof. I'm not seeing any more questions now. Wonderful, wonderful answers. I think we'll hand back over. Wait, one just popped up from Daniela. What if the HbA1c is elevated and the fasting glucose is normal? We'll use this as the last question.
Yes. So elevated A1C, but the fasting glucose is normal.
Yes, fasting glucose is normal. Yes.
Right. So now, especially if this is an elderly individual, and we published a paper, again, maybe about 20 years ago, looking at this very same phenomenon. Elderly individuals have more isolated postprandial hyperglycemia. So if that person has a fasting blood glucose, which is normal, and normal can mean a variety of things, but I'm just assuming that they're not in the range for diabetes, which is 7.0. But if they're 5.6 or greater, still kind of regarded as being in a normal range, those individuals may have post-challenge hyperglycemia, meaning if you do an oral glucose tolerance test, you will see an elevation into the diabetic range. So in a person who's like this, I would give them an oral glucose tolerance test. Yes, it's laborious, it's time consuming, it's inconvenient, it's a bit more expensive, but it's still the gold standard. And when you make a diagnosis of diabetes, you're going to change that person's life forever, right? Because health insurance, life insurance, mortgage rates, everything is going to change after that time. So if they have a persistently elevated A1C and their fasting is normal, but especially if they're elderly and the A1s and their fasting is above 5.6, I'm going to do an oral glucose tolerance test and put the matter to rest once and for all. A lot of these come up in like sort of insurance claims also too that sometimes occur. And in those cases, doing an OGTT is very, very useful to be definitive. Old-fashioned, but it works. It's still a gold standard.
If Dr. Gordon would allow, I think we still have some time for some questions. I see that this conversation has sparked the interest of some more persons. So a patient not known, wait, hold on. Is or are there any benefits to do insulin levels and our C-peptides and our amylase checks to determine IGT versus DM2?
All right, so if I have a person who I am wondering if they have type 1 diabetes, then I do want to investigate them. Now, if you don't investigate them, more than likely, down the road is going to become very evident, right? Because no oral agent is working in them. There's persistently hyperglycemic, etc. So, so it will become evident. But if the question is, could this person have, not classical type 2 diabetes, then they're going to need some investigations. And those are the investigations. Ideally, the preferred investigations are, especially if the person is relatively young, is a C-peptide. Now, not just insulin levels, but a C-peptide, because insulin levels can be variable in type 1 and in type 2 diabetes. So a C-peptide gives a better reliable indicator of endogenous insulin production. And you can do it as a fasting C-peptide. My preferred way of doing it is not a fasting C-peptide, but to actually measure the C-peptide after they've had a can of Boost or Ensure or Suppligent. In other words, that they have a liquid meal and 45 minutes later you do a C-peptide. In a person who has type 2 diabetes, the C-peptide is going to be elevated. In a person who has type 1 diabetes, is going to be flat. They're not going to have much response at all. So that's the gold standard way, but a fasting C-peptide still can give you the answer in the vast majority of people. Amylase checks are not going to be of any benefit. Anti-GAD65 antibody can be of benefit if it's done within the first 5 years of diagnosis. So if a person has classical autoimmune type 1 diabetes and you've diagnosed them with it, it's within 5 years of diagnosis, they may still have positive antibodies, and that could be another check that one can do. So you can do anti-GAD65, you can do fasting C-peptide, you can do stimulated C-peptide. Amylase is not going to be very useful.
Thank you so much. I think the final one will be from Granville. It says, could a 2-hour postprandial test help with normal fasting and high A1C?
All right. So a 2-hour postprandial is not going to be useful in a person who is not diabetic. In other words, when we say postprandial, that's when you tell the person, please go eat your breakfast and then we're going to do it 2 hours later. Or please go eat your lunch and then do it 2 hours later. Those are not recommended to make the diagnosis of diabetes because those are non-standardized different caloric loads, right? In one, a person may have a very heavy caloric load. In another, the person has little or no, I shouldn't say calorie, but carbohydrate load. So the carbohydrate load is going to be different depending on the meal. So if you're going to want to make the diagnosis of diabetes, then it has to be 2 hours after a 75-gram glucose load, not 2 hours after breakfast, not 2 hours after lunch. It has to be 2 hours from a 75-gram glucose load. So postprandial is not useful. Where postprandial is useful, the person is already known to have diabetes and you're checking on their control, right? So they're monitoring at home and you can see what their blood glucoses are after a meal, and that is useful in monitoring, but not in making a diagnosis of diabetes.
Prof, always a pleasure. Thank you so much. Thank you so much. Dr. Gordon, over to you.
Okay, thanks very much. Thanks, Prof. And thanks, audience, for staying with us. At this point, we have 634 persons with us, and we're going to take you over to Maurice from Rivis, who will give the sponsors presentation. Maurice, could you give us the sponsors presentation, please?
Hey, Maurice, can you just switch out of presenter view? Let me see what happens. Are you seeing your presenter view on your side now? No, you're not. Not sure why it's doing this. Also, do me an audio check. I'm not hearing you. Maurice, go ahead. Can't hear you. Audio check. Not hearing you at all. No audio from your end. Still not hearing you, Mo. In the meantime, let's try and fix your audio. If anything, we'll probably let you use Dr. Gordon's PC.
All right, I'm using Dr. Gordon's audio. Can you hear?
Yeah, totally fine. I'll share your screen as well. So you can just go ahead with your notes and let me know, and I'll just switch the screen for you. Go ahead.
Okay, so we're on the next slide. Great, thanks. So Rivis goes to great extents to offer quality you can rely on. The Rivis formulations are bioequivalent and pharmacopoeia compliant. This, of course, for patients means you get resulting better clinical results. The formulations are impurity-free and safe for use, as every single batch is double tested for potency and purity. Tested both in-house rigorously, but we also rely on external testing by WHO and ISO certified laboratories before releasing anything for sale. So this gives our physicians a lot of confidence in prescribing, and of course for patients, a lot of added protection and knowing that the product will work for them. Go ahead, Samuel. And just a little refresher on what a bioequivalent is. So Rivis brands are bioequivalent to innovator brands. This means we provide active ingredients that produce the same effect at the site of action when the time at the same time and the dose under similar conditions. So what you're pretty much getting is what you expect to get from the innovator brand, but of course, now at a more affordable cost as well. This makes the Rivis brands equally effective and safe as the innovator brands. Go ahead, sir. So Rivis considers several factors when determining our prices. This includes its impact on patients, first and foremost, diseases, the affordability, and of course, the other available treatments. We constantly, I want to say constantly, I mean constantly and consistently, ensure that our medicines have the right price. If there's no right price, then we don't have right compliance. Go ahead, Sam. So PIOS, and you would have heard pioglitazone being mentioned in Prof. Boyne's presentations. We as a company are the only ones that have the complete range of pioglitazone available in Jamaica. The 15, the 30, and the 45 milligrams, as was developed and offered by the Innovator brand globally. So Jamaica, as far as pioglitazone is concerned, has the full range as was offered by that Innovator brand as well. Offering proven effectiveness in type 2 diabetes mellitus with high fasting and postprandial blood sugars, diabetes with abnormal lipid profile, and we just spoke about NAFLD and how this can throw off the lipid profile, diabetic and non-diabetic patients with stroke or transient ischemic attack, PCOS, which is another prevalent condition in Jamaica, and as we're discussing today, NAFLD. Go ahead, Sam. Thank you. So let's review a little bit of the relationship between diabetes and NAFLD. At least 50%, and even with some of the data that Prof has presented, you're seeing 60 and 70% of diabetics have NAFLD. NAFLD leads to the risk of insulin resistance, atherogenic dyslipidemia, type 2 diabetes, and not just type 2 diabetes, but difficulty to manage type 2 diabetes. It also increases the risk of cardiovascular disease and events. And what you will notice is that a lot of our patients don't die from liver failure, but they die from the cardiovascular events that NAFLD can worsen. Type 2 diabetes now increases the risk of steatohepatitis, cirrhosis, and hepatocellular carcinoma. With PIOS, we can now address both these conditions as part of the treatment. Go ahead, Sam. So as mentioned, with the ACE clinical practice guideline recommendations, PIOS is a highly viable pharmacotherapy to be used in persons with type 2 diabetes and NAFLD or NASH. As an important note, the recommendations extend across low, intermediate, and high-risk stratification, so PIOS can benefit all the patients across the spectrum of NAFLD. Go ahead, sir. So furthermore, PIOS can help alleviate NAFLD by having positive effects on the liver enzymes, insulin resistance, and blood lipids. These in addition to exerting anti-inflammatory, which is a whole big concern on its own, and antifibrotic effects. Pioglitazone 30 milligram in just 4 months resulted in improvements in fatty liver stage, liver size, BMI, and fasting blood sugar and lipid profiles. Pioglitazone excelled compared to most other anti-diabetic medications in managing NAFLD. And this is critical for Jamaica, as PIOS is available in Jamaica affordably and more easily administered. So, PIOS offers physicians and patients the only full range of dosing options with bioequivalent efficacy and safety to treat any level of NAFLD, confidently and affordably. As we consider our chronic patients, I must also mention a brand that has been effectively treating our hypertensive patients in Jamaica as well. This is, of course, our Losartan. Go ahead, sir. Another high-quality bioequivalent, Losartan has been offering physicians the opportunity to effectively tackle hypertension in their patients. And we've had Losartan being used in Jamaica for a long time. Losartan in the ARB class, that is first choice for patients with heart failure, stroke, diabetic nephropathy, hyperuricemia, and erectile dysfunction. Noted for being a Losartan option that has been impurity-free and available in all the indicated doses, Losartan offers, like the entire Rivis line, high quality and affordability to give patients the best options in treatment. Go ahead, Sam. So Rivis continues to provide the right quality, the right price, and we look forward to continued support to give Jamaicans the healthcare they deserve. We partner with our physicians. I have been in the industry for a long time, and one of the consistent things I've always heard is, boy, we need medications that are more affordable, but we don't want cheap quality. We know in Jamaica have bioequivalents at prices that compete with regular generics. We ask our physicians for your added support as we continue to support you and our physicians. Thank you.
Thank you very much, Maurice, for the sponsor's presentation. Standing by to present our second presenter is Mrs. Debbie Neal. She's going to introduce Dr. Mike Mills. Debbie, can you go ahead and introduce Dr. Mike Mills for the second presentation of the evening? Thank you.
Good evening again, everyone. Dr. Mike Mills is a graduate of the Doctor of Medicine Internal Medicine program at the University of the West Indies, Mona. He completed his subspecialty training in gastroenterology in Edinburgh, Scotland. He's a member of the Association of West Indian Gastroenterologists, the American Society of Gastrointestinal Endoscopy, a fellow of the American College of Physicians, a fellow of the American College of Gastroenterology, and a fellow of the Royal College of Physicians. He is the Vice President of the Medical Association of Jamaica, Governor of the West Indies chapter of the American College of Gastroenterology, and a past president of the Association of Consultant Physicians of Jamaica. He has participated in numerous public awareness events and media activities covering digestive diseases, often with emphasis on colon cancer screening, and liver-related diseases. He is the owner of Phoenix Gastroenterology and Health Services. Thank you so much for joining us, Dr. Mills.
Thank you very much for inviting me, and good evening, everyone. And it's been a very entertaining, informative evening speaking about a condition which was mentioned as being, first of all, forgotten, also mentioned as being an emerging condition, but the reality is that it was largely well recognized, but just ignored for a long time. And so we're going to try and look at some of the clinical aspects of what is more commonly termed now as MASLD. MASLD is an alternate way of pronouncing it as well, but MASLD essentially is what we want to get individuals to highlight as the condition which was formerly known as non-alcoholic fatty liver disease. So there is a little bit of disclosure. I'm going to start by sharing my screen, but I do want to also remind—
Shall we run the polls now, Doc?
Yes, just after my initial disclosure slide. So Rivis has invited me to speak and they have provided an honorarium, but outside of that, I have no other disclosures. So at this time, we're going to run a short, very brief pre-test. I'm going to ask you to participate, and Sam, if you can just put that up and allow individuals to answer the questions that come up.
No problem. So it's 4 questions. This is question 1. MASLD stands for in the interest of time, we'll run each of the questions for about 30 seconds to about 45
30
seconds.
is long. I think we can go with even 10 or 15 seconds, not a problem.
Sure, no problem.
So the first one, MASLD stands for metabolic anabolic steatotic liver disease, major anabolic steatotic liver disease, major alcoholic steatotic liver disease, metabolic dysfunction associated steatotic liver disease.
And these are the results.
Okay, so we have a 50%, and then we have another 39 saying metabolic anabolic steatotic, and then smaller numbers. So just remember, we're going to look at them at the end of the presentation and see if, we transferred any knowledge or if you already knew what you're speaking about. Next question.
Sure, question 2 is up.
Assessment of MASLD can be done using any of the following except triple phase CT scan of the abdomen, transient elastography, MRI PDFF, or serum biomarkers. So which one is not used to assess MASLD?
All right. 5 seconds.
Ignore. Okay, and we have quite a wide spread. And I said, which is not used, and the majority suggested transient elastography should not be used, and the others should be, but no problem. Third question. Patients with MASLD and diabetes are at low risk for cirrhosis, the FIB4 of greater than 1.3, or low risk for cirrhosis with a FIB4 of less than 1.3. So you did hear a little bit about FIB4s. So is it low risk with a FIB4 greater than, or low risk with a FIB4 of less than in patients with MASLD and diabetes.
5 seconds left. If you're not seeing the question, it's probably because of how you're logged into Zoom, whether it's on your browser or a device that needs updating of the app. But yet we have some 230 persons who have participated, and the results
Are pretty much split.
pretty much split.
All right. And then the final question. So MASLD with fibrosis can be improved using, and choose one, targeted weight loss of between 5 to 10%, rosiglitazone in patients with type 2 diabetes, resmetirom, or high fructose corn syrup diet. So which of these can be used to improve fibrosis in patients who have MASLD with fibrosis?
5, 4, 3, 2, 1.
Okay, so it's between targeted weight loss of between 5 to 10% or rosiglitazone. And most people are actually selecting rosiglitazone as being useful in managing patients who have fibrosis. All right, no problem. So bear that in mind. At the end of the presentation, we're going to go back over them and see if we can highlight what the correct answers are, and you can see if anything was useful for you. So let me jump into the presentation. So I already spoke about NAFLD, which was the old name, and by consensus, we've changed certain things. So it's now MASLD or MASLD if you want, no problem, but just not NAFLD. So no more referring to it as fatty liver, okay? No fatty liver, no NAFLD, no NASH. So it's metabolic dysfunction associated steatotic liver disease. Long name, and there's a lot of debate as to what the final name should be, but this is the one that reflected most commonly what the condition is without necessarily being associated with the stigma of fatty or alcoholic. And so it also represents the pathophysiology behind it, as elucidated by Professor Boyne earlier. So the new terms to learn for fatty liver in 2024, NAFLD is now MASLD, NASH is MASH, which is metabolic dysfunction associated steatohepatitis, where there's inflammation. Then there are some new overarching terms. So steatotic liver disease is a new category of disorder, SLD. And then instead of alcoholic liver disease, it's now being called alcohol-associated liver disease. So again, removing the term alcoholic, which is something associated with a stigma. So you did see this slide before, and it's just to introduce to you this new approach. So if anyone who presents to you in your office with a diagnosis of fatty liver, you would now say, well, this person has steatotic liver disease. And what is the cause of the steatotic liver disease? Are we referring to somebody who has evidence of what is now MASLD? Or is it someone who has a significant history of alcohol consumption? Do they have alcohol-associated liver disease as a cause of their fat? Or is there an overlap between the two? If there's an overlap, then they have what's called MET-ALD. And there are criteria here, depending on how much alcohol they consume and what metabolic risk factors they may have an overlap. Then there are other causes of fatty liver, cryptogenic, where there's no specific cause elucidated. And then there's some specific etiologies that we can identify. So certain drugs, and then certain conditions like especially hepatitis C, for example, can be associated with fatty liver or steatotic liver disease. So this is a category that we want to be entertaining when we speak about patients who have steatosis. Now, how do we approach this category? So the patient presents with steatotic liver disease, and it's usually by some kind of imaging, on ultrasound most commonly. The first question you want to ask, is there presence of any of the cardiometabolic criteria? If they don't have any, and there's no significant history of alcohol consumption, then you want to look for another cause of steatosis. If you can identify the specific cause, then it will be categorized as either drug-induced, whatever the specific disease is, like hepatitis C or any other cause. If there's no cause identified, then it's cryptogenic steatotic liver disease. If they did have cardiometabolic criteria, so you looked at them, you made the assessment, and there was a history of alcohol consumption, you characterize if it's more than 50 grams in women, 60 grams in men, then it's alcohol-related liver disease as the cause of their steatosis. If, however, it is a lesser amount of alcohol and they have evidence of dysfunction associated with one of these metabolic parameters, it will be a combination of met ALD, if they have alcohol, and some of these metabolic features, or if they don't have alcohol, it will be purely metabolic dysfunction associated steatotic liver disease, or MASLD. And this is an overarching term which can be further characterized clinically by the presence of inflammation, at which point they'd be termed as having MASH, or metabolic dysfunction associated steatohepatitis. So there's a way of deciding what essentially is causing the amount of fat in the liver and what ultimate diagnosis you want to make. And to go over the cardiometabolic criteria just briefly, so of course the BMI, waist circumference, your glucose, as mentioned before, your blood pressure, your lipid profile, and the typical things that we want to do to decide if the person has at least 1 out of 5 to decide if they fulfill the criteria for what is now called metabolic dysfunction associated steatotic liver disease. The natural history of which is important to recognize. So Mikey Bowen did speak about this to say that most individuals, 80%, who have what is now MASLD, will have just fat in the liver, or steatosis. There is not going to be much inflammation here. And of course, in the absence of inflammation, there's going to be minimal progression to fibrosis and reduced incidence of liver-related mortality. So the majority of individuals with fatty liver will have fat represented, but will not have evidence of inflammation. The 20% who do have steatohepatitis or inflammation are the ones who are at increased risk of progression to cirrhosis, and then the complications of cirrhosis, which are hepatocellular carcinoma or decompensated chronic liver disease. And of course, there's increased cardiovascular and liver-related mortality and malignancies, especially in individuals who have fibrosis. So the key thing is to decide whether your patient has only steatosis or has evidence of inflammation, because these patients with inflammation are the ones that we're going to be worried about for progression. So we must identify whether they are at risk for progression. And that's, if there's nothing else to take away from the presentation, is that the patients who present need to be risk stratified to decide what the risk of progression is. The global prevalence, you saw this slide earlier, has been matching the increased prevalence of obesity and diabetes over the decades. And of course, we want to pay attention in our population because, as you know, the prevalence rates have rapidly increased with time as well. Just a little more local data. So we did try to look at the prevalence of fatty liver in 2016, and this published data suggested that all comers who went to the university hospital and had an ultrasound for any reason, when we look back to see what the diagnosis of fatty liver prevalence was, 2.4% of individuals who presented at the time had a diagnosis on ultrasound of a fatty liver. So this is not an incidence study. It was just looking to see at a snapshot whether or not we were seeing patients who had fatty liver. What were the risk factors that were identified in this population of individuals? Well, 85% were obese. Diabetes mellitus was present in 40%, dyslipidemia in 21%, and hypertension in 51%. So some of the typical things that we would expect to find, we had been seeing at that time. Now, the severity assessment for individuals who present with fatty liver in the early days would have been confined to doing a liver biopsy. So at the time, a liver biopsy was performed in some individuals presented at the time with fatty liver, and the changes represented here, 10% of those individuals had incidental steatohepatitis, and there was evidence of advanced fibrosis in 10%. So the distribution is similar. We recognize that most individuals will not have severe disease, but we do need to identify quite readily those individuals who are at risk for progression, which means that we need to be looking, first of all, for steatotic liver disease. But as Professor Boyne mentioned before, doing population screening for metabolic associated steatotic liver disease is not something that's advised. The population is just too large, the yield is not going to be favorable, and resources would be better used in identifying individuals who are at increased risk. So who do we need to be screening for steatotic liver disease? Broadly speaking, individuals with obesity who have the highest risk, and individuals who have any of the metabolic risk factors. So especially in patients who have type 2 diabetes with obesity, you want to make sure that you pay attention to their liver. History of alcohol consumption also increases the risk. So even if the patients are not diabetic, once there's a history of alcohol consumption, you need to be looking to see if there's evidence of any other metabolic component and what the degree of inflammation associated with excess alcohol consumption is. Patients who have type 2 diabetes, patients who have obesity, hypertension, hypertriglyceridemia, hypercholesterolemia, and a history of liver disease are all patients who you need to pay attention, especially to decide if they have evidence of steatosis. And as mentioned previously, males above the age of 50, postmenopausal females, and individuals with multiple cardiometabolic risk factors are at higher risk for progression and definitely need to be identified. So let's look at a case. So here we have a 55-year-old male, type 2 diabetes. He's on metformin, no history of alcohol use, no signs of clinical liver disease. Clinically, examination was unremarkable apart from being overweight, the BMI of 29. His weight was measured at 90 kilograms, normal platelets, AST mildly elevated at 40, ALT mildly elevated at 34, normal bilirubin, GGT, and prothrombin time. And then you have some other indicators here. So he had he had his FIB-4 measured, which was 2.43. He had something called a CAP, which was 350 decibels per meter. And then he had a liver stiffness measurement of 12 kilopascals. So we need to pay attention to these numbers to decide, first of all, what questions do you need to answer when a patient presents to you like this? First of all, you need to ask yourself, should I be looking for steatosis? Does the patient have steatosis once you decide to look for it? Does the patient have advanced fibrosis? And is the person eligible for some type of pharmacological treatment? So once you identify those questions, answer them, you should be well on your way to deciding how to manage and not miss patients. So the first thing, should you be looking for steatosis? Now let's look at this case again. So I've highlighted in the red here the things which tell you that you definitely need to look for steatosis in this person, type 2 diabetes. So that alone says, yes, I need to look for steatosis here. Overweight, so obesity, diabetes, you need to look for steatosis. Even if a person has abnormal liver function tests, that's not the reason to be looking for steatosis. There are other causes which can present with transaminitis, but the fact that just the type 2 diabetes and overweight, even if the LFTs were normal, you need to be looking for steatosis. So, okay, does the patient actually have steatosis then? What is your primary assessment? How do you go ahead and decide that the person actually does have steatosis? Of course, on ultrasound, the commonest way that the presence of steatosis would come to mind, and most individuals have an ultrasound for some other reason, not necessarily looking for steatosis, but the sensitivity and specificity of ultrasound is quite high at identifying individuals who have an excess amount of fat. And as you can see here on ultrasound, the liver which has excess fat is brighter or whiter than the normal liver, which is here, has a grayish appearance. And the ultrasonographer will compare the echo pattern of the liver to something like the spleen or the kidney, which is next to it. And once they have a similar echo pattern, it's enough to signify that there is significant amount of fat. Now, The amount of fat will determine how bright the liver is. And of course, it is not 100% sensitive. So you can miss cases, especially if there is very mild amount of steatosis. So less than 30% of the fat, the liver being affected by fat, the sensitivity of the test will fall. But you can identify quite readily and is most commonly the first indicator that individual does have steatosis. So an ultrasound would indicate it. And traditionally, when the ultrasound comes back showing fat in the liver, I'm pretty sure if we were face to face and I were to ask everyone here to put their hands up, if you've ever seen an ultrasound come back to you and the diagnosis from the radiologist is fatty liver, and you looked at the ultrasound, saw fatty liver, and decided to basically ignore it, I'm sure most hands would go up, because traditionally, individuals would just not pay attention to fat, or would just say, oh, we have a little fat in the liver, but there's nothing to worry about, or not even mention it to the patient, or sometimes not even look at it yourself and have a blind spot. And it was often ignored traditionally. And that was the approach as far back as recent as 2016 when we did our study. And the most obvious way of deciding if there's a problem in terms of fat would be actually biopsying the liver, which is the gold standard test to diagnose fat in the liver. So ignoring fat in the liver has risks, as highlighted by Professor Boyne earlier. The risks of progression for cardiometabolic disorders and cancers and hepatocellular carcinoma and end-stage liver disease are there. They can't be ignored. In terms of liver transplantation, fat or steatosis is rapidly becoming the #1 reason for liver transplant in the developed world. And so it's something that cannot be ignored. Doing a liver biopsy for every patient who presents just to find out if they're at risk for progression also has problems, because if you were to do that, first of all, there's so many patients, you can't biopsy all of them because of technical availability. And of course, the complications associated with liver biopsy will be far greater than the benefit to be gained. So there must be some other way of deciding if the person who has steatosis or fat in the liver is at risk for progression. And those patients need to be identified without exposing them to liver biopsy. So you want to know, does the patient have advanced fibrosis? When we speak about advanced fibrosis, there's a scale that we're using, and the pathologist will report F3 and F4 as the stage of fibrosis. And once a person is at this stage, that's a major prognostic indicator. So the higher the degree of fibrosis is the more progression towards cirrhosis, of which that's F4, and of course increased risk, as we said before, of hepatocellular carcinoma or liver failure. And of course, the mortality, which is liver-related, is increased at F3 and F4. And all-cause mortality, as we said before, are increased at these stages. So we need to identify individuals to see if they fall in this category by all means. And this is our primary goal, to figure out which patients with fatty liver or steatotic liver disease or MASLD are going to progress. So that means you need to do some kind of secondary assessment. So you already know now the patient does have an ultrasound showing that there is steatosis. You need to move on to decide, does the patient have advanced fibrosis? You can't biopsy them, but there are some other things you can do. And you know that the challenge is to identify these patients due to the large number that are coming to you. If you pay attention to your patient population, you will see that a majority of patients will have either an incidental finding. If they have diabetes, up to 50% will have steatosis, and you can't do any invasive testing on all these patients. So you need to have a cost-effective way of identifying the patients who are the minority, but at risk for developing these complications. Now, the gold standard, as we said before, is a liver biopsy. So there are different stages to fibrosis. We want to identify the individuals who have bridging fibrosis. So if you remember your anatomy or histopathology, in the trichrome staining here, you're seeing these blue areas which represent fibrosis. And in the early stages, so normal liver, F0, you don't see any fibrosis at all. F1 to F2. The fibrosis is confined around either the central vein or the portal triad. So it's distinct areas of fibrosis. When the fibrosis tracts tend to connect between either the central vein and portal triad or between central veins and portal triad. So you have bridging, there's a bridge formed between these. So here's the bridging starting. So then we get F3, and then when you get more organized nodules associated with it and more bridging and thicker fibrosis, then that's fibrosis associated with nodular regeneration, which, as you know, is cirrhosis. That's a gold standard, but you need another way of figuring out if that's present, and that's where the non-invasive testing comes in. So the whole key thing to take away, apart from the name change, is that you need to now be familiar with some kind of non-invasive way of assessing your patients for the presence of MASLD. There are two different types of serum biomarkers. So serum biomarkers or blood tests essentially can tell you without biopsying the patient. They're the non-patented ones and the patented ones. We don't have any of the patented ones, so you don't have to worry about those, but the names are here. And if you see a patient coming from overseas with one of these, it's an indicator that they had testing to see what their risk is. You, however, can definitely do one of your easy regular blood tests. So your APRI, or your AST to platelet ratio index, is a validated test score. Your NAFLD fibrosis score is also another validated score, which measures BMI, glucose, albumin, and some other markers. But the one that we want to focus on and get everyone to learn how to do is your FIB-4, or your fibrosis 4 score. So the FIB-4, as was mentioned before, just plug it into your phone. Get the app, ND Calc, for example, or go on the website. You just need the patient's age, an AST level, the platelet count, and the ALT level. Plug them in to the app, it will give you the score, and it will tell you what your patient's risk profile is. So, number to remember, if your FIB-4 score is less than or equal to 1.3, low probability that the person has fibrosis, and so the chance of them progressing is almost 0. If the person has a very high score, more than 2.6, high probability that they have fibrosis. And so these patients you need to do something about because they're at risk for progression. The problem is you have patients in the intermediate zone. So their score comes back between 1.4 to 2.5. You can't ignore them, but you can't leave them alone either. So you need to do something to decide what their risk is. So there's some other tests that you can do, which are still non-invasive. These tests include elastography. There are different tests available for elastography. 3 main ones that we have available. So VCTE, or vibration controlled transient elastography, which is done using a proprietary tool called a FibroScan, which you may have heard about. And this simple test is almost like an ultrasound probe. It will tell you a score called the controlled attenuation parameter, or CAP score, and that will tell you if there is basically fat in the liver. So the test, simple test, takes about 5 minutes to perform. It tells you what the degree of fat is. It gives a number depending on how much fat there is. There are some other things which are also available. So the ARFI, or acoustic radiation force impulse, or 2D shear wave echo. So basically it's the same kind of technology as an ultrasound, but it also propagates sound particles or sound waves through the liver and measures the refractive time back to the transducer and gives an idea as to degree of fat, as well as the degree of liver stiffness. Then there's MRI, so you can do an MRI as well, which basically a specific type of MRI looking at protein density fat fraction, which tells you again how much fat is present in the liver. So these are the 3 different types of elastography, which will give you an idea as to the degree of fat and also give you an idea as to the degree of fibrosis. But for the fat aspect, first of all, so your FibroScan, and this is what the machine looks like, there are different ones. This is the one that's available in my office that I use, but essentially it's a portable machine. As I said, the cutoff for the CAP score If the CAP score is greater than 275, then there's a greater than 90% sensitivity to detect a liver of more than 5% steatosis. So it's fairly sensitive in terms of picking up degrees of fat. It's not recommended as a first-line diagnostic tool, however, so you're not going to go out and just scan everybody to see if they have fatty liver, because of course there are costs associated and there's no head-to-head data at the moment comparing it to something like a liver scan. So the machine will give you the CAP score, and it will also give you another reading called the LSM, or liver stiffness score. So those two measures will tell you how much fat there is and basically what the risk profile is. So with regards to non-invasive tests, I want you to pay attention to the ones in red. We have FIB-4 available, and this is the test that you need to start with once your patient is identified as having steatosis. It's readily available and the cost is low. In the middle, you have FibroScan, and then, of course, more expensive and less readily available would be an MRI, which also gives you good information. And there's good data to support the use of these tests. The area under the receiver operated curve and the sensitivity and specificity of each of these tests show that they are well suited to identify patients who have steatosis, and so should be used reliably. In terms of liver stiffness score, that is to tell you if the patients have fibrosis. So you can tell if they have steatosis or fat, and you can tell how stiff the liver is, which is an indication of how scarred the liver is. So the more stiffness is the more scarring presumed. And you get different measures using elastography. And the different measures will tell you what category. And you're good at extremes. So if the liver stiffness score is greater than 11, then the patients are having high amounts of fibrosis. If it's less than 8, then they have no fibrosis. And of course, this is useful information because this is how you decide what to do with your patient. So what should you do? Do you do all tests and then see what happens? The more tests you do, obviously, the more information you get. So no, the approach is not to pair the tests. The approach is to do sequential testing. So if you do sequential testing, meaning you do your FIB-4, which is a simple blood test first, then if the FIB-4 tells you what's likely, in other words, if they're at low risk, no more testing. If they're intermediate or high risk, then you do some further testing to characterize the degree, whether they're F2, F3, F4. If you can do that sequence, you reduce the need for liver biopsy up to 70% of patients, and therefore characterize them by saving on costs as well, but improving on your diagnostic tools. So the approach then, FIB-4 as your primary assessment. If the FIB-4 is greater than 1.3, then you go on to do subsecondary risk assessment, which is basically like your FibroScan or a liver biopsy, depending on how high it is. And if it is not, so if your FIB-4 score is not greater than 1.3, then you can afford to have your patient reassured that yes, you still have fat and you need to take some interventions, but your risk for progression is not there. So low risk, FIB-4 less than 1.3, advise management. You don't need to refer the patient, but you do not ignore the patient. Intermediate risk, FibroScan or liver biopsy. If you're not sure, obviously you need to refer them on at that point. So if it's less than 1.3, you're okay. Anything above that, then their risk needs to be characterized further. If the liver stiffness score, which can only be gotten on the FibroScan, indicates F3 or F4, those patients are at the highest risk, and you may consider doing either a biopsy to characterize further, or if they're definitely in the intermediate range, you need to follow them closely or potentially biopsy these patients. And of course, their interventions will be more intense because these are the patients who you definitely want to prevent them from going on. So our patient then had these scores. FIB-4, 2.3, 2.43, so definitely more than 1.3, so he has evidence of some fibrosis. CAP score, more than 275, 350, so he has fat. liver stiffness score, which he went on to have, was 12. So again, either F3, F4, so a lot of fibrosis. So all these indicators suggest there's a lot of fat and a lot of fibrosis already. So this patient can't be left alone. Some intervention needs to be had because he's at risk for progression. Now, the goals of treatment are to improve the metabolic abnormalities, decrease inflammation, target the liver lesion. So you want to prevent fibrosis, you want to stop it if it's there, or you want to reverse it ideally. And you can reverse fibrosis. So not because there's scarring means you can't do anything. You want to prevent cirrhosis and the complications. So those are your goals of treatment. Lifestyle intervention is one of the primary things that you can do in patients who have MASLD. So if patients are overweight or obese, you need to achieve a sustained weight loss of around 10% to get significant improvements in the liver enzymes and in the histology. Now, if the liver enzymes are off, that means they had steatohepatitis, which means that they're not just simple fat. So you need to apply more stringent weight loss measures. If it was only fat alone, they still need to lose weight. 3 to 5% is enough to improve steatosis. So you have a target, not as aggressive. If they have inflammation or fibrosis, 6 to 10% will be your target, and the more weight you lose is the more you improve. So first line therapy, always reduction calorie intake, weight loss, exercise. Reducing caloric intake alone will improve fat, and it will improve your insulin resistance and definitely go a far way in improving the patient's MASLD. There are different ways of reducing calories, so different diets available. It really doesn't matter what you call the diet, whether it's periodic fasting or time-restricted feeding or alternate day fasting, manipulating of one of the macronutrients, so a low protein diet, low lipid, high carbohydrate. There are different combinations, as you can see here. Different names: Atkins, ketogenic, paleo, Mediterranean. All of them have been shown to improve individuals' liver fat status as long as they are associated with weight loss. So the important thing is that you need to maintain your calorie restriction in such a way that whatever is chosen, you're able to achieve the target that you set. So whether it's between 3 to 5%, 6 to 10%, or over 10%. And it doesn't matter what time. So this is just a trial looking at eating in the morning or eating in the evening. It doesn't really matter how you manipulate the calories. Restricting calories definitely plays a role. Now, the Mediterranean diet, more so than any other diet, has been shown to have the most effective amount of reduction in hepatic fat content, which is HFC. So they compared the Mediterranean diet to the standard antihypertensive DASH diet. Both individuals who started off with a significant amount of hepatic fat, after Mediterranean diet, after 18 months, they were down to 5% hepatic fat content. Also down with the DASH diet, but to a lesser degree. The cardiovascular risk, of course, improved significantly more in patients on the Mediterranean diet. So the Mediterranean diet, if you're going to choose any one diet, once it's available and affordable and accessible, patients should be encouraged to be on it. But if they can't, no problem. You still need to choose any of the diet. Now, there's less evidence for the more commercial diets, but the key thing is weight loss and sustainability. Sugar is definitely a problem. So the incidence of MASLD have increased with the increased sugar content and obesity over years. So cutting back on especially high fructose corn syrup, there's a lot of data showing that in particular, high consumption of high fructose corn syrup, which is in a lot of our processed foods, those individuals have a higher incidence of NAFLD compared to those who do not consume higher amounts of high fructose corn syrup. So getting that out of the diet, also looking at your sugar sweetened beverages, definitely is something else to target. In terms of good foods, so we spoke about protection by the Mediterranean diet. So nuts, definitely. Cutting back on red meat and soft drinks. Having high fruit and vegetables is a good thing. Decreasing red and processed meats, having more plant-based proteins. High-fat dairy is also problematic. Ultra-processed foods, problematic. Soft drinks, problematic. So there are different things that you can target in your patients to see how best to improve their weight. Now, part of the problem with weight loss diets, of course, is adherence. Okay, so you need to have long-term adherence because, as you know, most data shows that patients can maintain it over maybe up to a 6-month period, but if you're not strictly monitoring them, they tend to regain some weight. So it is an intense lifestyle change, and patients need to be sensitized that they should be prepared to make some of these changes. Exercise. So exercise in itself, on its own, is not sufficient to reverse significant fat content in the liver, but in conjunction with dietary changes has been shown to be effective. This forest plot essentially demonstrates that it doesn't matter what type of exercise, whether it's aerobic or high intensity resistance, there is always an improvement towards reducing your fat liver accumulation. So encouraging individuals to have high impact exercise or aerobic exercise or resistance training doesn't matter. The key thing is ideally 150 minutes per week of exercise would be encouraged. Now, the greater the degree of weight loss is the better the outcome in terms of hepatic steatosis or fat content, as well as the ability to reduce and also reverse fibrosis. So greater than 10%, individuals who lose more than 10%, 90% will have resolution of their steatohepatitis. That's inflammation. Fibrosis regression, 81% can actually have improvement if they lose more than 10% of the body weight of scarring or fibrosis, not cirrhosis, mind you, but fibrosis, which is still important. And of course, steatosis, which is just simple fat, more than 10%, all patients will lose fat. So if you can achieve more than 10%, then your outcomes are much better. Now, if you achieve only 5%, even just up to 5%, you will get improvements. And the key thing is most patients, so the greater the degree of percentage body loss that you try to achieve is the smaller the percentage of patients who are able to achieve it in the real world setting. So the key thing is to try and stick with your patients and have an organized program of weight loss, because sustaining it is an important thing to keep in mind. Now, medications are definitely looked at as a more predictable way and easier way of reducing your fat content. And some years ago, not too long ago, when we presented this topic, this slide would have said that there are no pharmacological treatments approved for MASLD. But just this year alone, there's one medication. So only one medication is FDA approved. And yes, we're not governed by the FDA. And so there are lots of off-label things that we can do. But in terms of medication, which has been proven to show improvements in fibrosis in patients who have F2 and F3 MASH, only resmetirom, which is a beta thyroid hormone receptor agonist, as you heard earlier, has been shown to improve fibrosis. So this is the only FDA-approved medication. It was approved early this year. So only in March of this year has there been a medication. And it's the only one which is approved. Now, there are other medications which we have experience with clinically, which have off-label use in patients who have steatosis. So vitamin E, there is a lot of work showing as an antioxidant, 800 international units per day, has been shown to improve liver histology in patients who are not diabetic and who have steatohepatitis. So once there's inflammation and the patient is not diabetic, And why these two stipulations? Because that's where the data is. So the data was done in patients who were not diabetic and who had steatosis with inflammation. Outside of that, because there are some risks associated with high dose vitamin E, it is not recommended, especially in patients who do not have evidence of steatohepatitis. So ideally, vitamin E can be used, but only in a select group of patients. There are other agents, as you heard about earlier. So pioglitazone is the only one of the thiazolidinones that's available as an insulin sensitizer to have been shown to have this positive effect in patients who have metabolic dysfunction associated with steatotic liver disease. So rosiglitazone is not the same as pioglitazone and has not been shown to have the same beneficial effect. So if there's an agent to be selected in a specific population, so patients who are diabetic, who require this agent as an off-label use, it can be used in patients who have fatty liver or steatotic liver disease and diabetes. It has also been shown to be successful in patients who are not diabetic, and I'll touch on that shortly. So the GLP-1 agonists also, semaglutide, which is in the news a lot as a weight loss medication, has also been shown to be beneficial. And then the SGLT2 inhibitors have also been shown in the right subgroup of patients. So as we said before, pioglitazone improves steatosis. So if there's fat, even fat with inflammation, even fibrosis, and of course the cardiovascular benefit is well known. Same thing for GLP-1 receptor agonists and SGLT2 inhibitors, even though the effect for SGLT2 inhibitors is less marked or unknown. And so the utility in patients is not as profound as in those who have been using pioglitazone or one of the GLP-1 agonists. So pioglitazone, as I said, most patients who were trialed with this agent had type 2 diabetes, but here you see that there are some studies in patients did not have diabetes at all and still had improvements in fibrosis. Not a large amount of patients, because of course the indication for use would have been predominantly for diabetes and not for fatty liver. So it's not FDA approved for the treatment, but we do know based on the mechanism of action and its use over the years that patients can benefit from using pioglitazone. Same thing for the GLP-1 inhibitors, agonists. Semaglutide in particular is the one that is most commonly studied and has a significant 41% reduction in steatosis. And this correlates directly with the amount of weight that is lost. Similarly, if there is inflammation, so the degree of inflammation for this agent is highest in the studied literature. SGLT1 inhibitors, the data is not as robust, but you do have improvements in steatosis, even though not so in fibrosis or steatohepatitis. So it would not be one of the more readily recommended agents. All right, so the key thing to remember is that the greater the degree of weight loss is, the better improvement in histology and inflammation that you get. And there are other agents that can be used to try and achieve this weight loss. So we're going to start with lifestyle modifications, pharmacotherapy, and ultimately you can also offer surgery. So bariatric metabolic surgery is not indicated primarily to manage steatotic liver disease. It's managing obesity. But of course, the effect of managing obesity is also going to be beneficial in terms of improving liver histology. So bariatric metabolic surgery using either the Roux-en-Y gastric bypass, where you're basically bypassing the bulk of the stomach, or sleeve gastrectomy, which is fast becoming the most common means of bariatric surgery. And that's where called metabolic surgery because it actually has beneficial effects on the metabolic profile, not just weight loss, but of course, diabetes, sleep apnea, and cardiovascular outcomes, in addition to steatosis. And then an adjustable lap band, which is not as popular anymore. Of course, the patients have to be properly selected. So the management is for patients who have severe obesity, particularly in the presence of type 2 diabetes. The fact that they manage their liver disease is also an added benefit. It's not recommended, however, in patients who have decompensated cirrhosis, but is an option. So you get resolution or improvement of fat in the majority of patients who've undergone bariatric surgery once there's improvement or greater than 20% weight loss, improvement of steatohepatitis, improvement of fibrosis, and complete resolution of inflammation. So the majority of patients with successful bariatric surgery will have significant improvement in their MASLD. Now, surgery is highly effective, but the medications have also now approached the point of causing weight loss comparable to surgery. And so especially you're seeing here, there's newer agents, which are the GLP-1 agonists outside of semaglutide are approaching significant degrees of weight loss up to 20%, which is probably going to change the utility of bariatric surgery pretty soon, if it's not already doing so. There are other weight loss medications which don't have the same degree of weight loss. And of course, they're not indicated, as I said, for management of primarily steatosis, but patients who are on these medications can achieve significant weight loss and have improvements of their liver profiles as well. So your treatment options for metabolic associated steatotic liver disease are weight loss primarily, reduction in calorie intake as a primary means of doing that, and exercise in combination. And to conclude, the things I want you to take away from tonight are, first of all, that what was previously called NAFLD is now MASLD. If you want to say MASLD, no problem. NASH is now MASH. You need to assess your patients who have presented, especially with a metabolic syndrome, and diabetes and obesity stand out in particular. You need to look for steatosis, not to ignore it. All the patients who have type 2 diabetes need to be screened, but the screening doesn't have to be expensive. You need to assess fibrosis, so you need to do your blood test, take out your app, calculate your FIB-4 score, check to see what their risk for progression is, and see if you can reduce their risk. If they're intermediate or high risk, they need to have further assessment done to see what the staging is and see if you can cause regression of the fibrosis, because there are a range of options available outside of just diet and lifestyle, which are becoming available once other factors are taken into consideration. So we're going to now stop there and do the post-test to see if your answers are, different from before. So here's the first question. MASLD stands for, is it metabolic anabolic steatotic liver disease? Is it metabolic anabolic steatotic liver disease? Is it major alcoholic steatotic liver disease or metabolic dysfunction associated steatotic liver disease? Which one is it?
5 seconds. And hear the results.
Okay, so now we've gotten it correct. Most people, a few people who need to pay attention. So yes, definitely. Second question. Assessment of MASLD can be done using any of the following except triple phase CT scan of the abdomen, transient elastography, MRI PDFF, serum biomarkers. So which one are we not using?
10 seconds.
Okay, yes.
Okay.
So correct answer did come out, and it is CT scan. We are using all the others. So all the others are available. Transient elastography is called FibroScan. It is used for assessment. MRI can be used. It's not commonly used because of the cost and availability, but it's very accurate and it can be used. And of course, serum biomarkers can also be used, but it's not CTs because of the radiation risk and the fact that it's not as sensitive. Third question. So patients with mast cell and diabetes are at low risk for cirrhosis with a FIB4 of greater than 1.3, or are they low risk for cirrhosis with a FIB4 of less than 1.3? And the FIB4, as you remember, is your blood test, which you plug into your phone. That's the first test you're going to do with a patient who presents. We want to know if they're at risk.
10 seconds remaining. 5.
Okay, yes. So the correct answer, FIB4 of less than 1.3 means the patient is at low risk for cirrhosis, and so you don't need to refer these patients. You can if you want, but you don't have to, because there are going to be a lot of patients like that. And then the final question. So MASLD with fibrosis can be improved using targeted weight loss of 5 to 10%, rosiglitazone in patients with type 2 diabetes, resmetirom, or high fructose corn syrup diet. So how do we improve it? Improve fibrosis.
Five seconds left, guys.
Okay, back to school. Okay, so resmetirom is only one that we can use here. So let me just make sure everyone is clear. Fibrosis is scarring. So that person who has scarring is the more at-risk person, and we need to get their weight down. And the only way to improve it is to get their weight more than 10%. So less than 10%, still improvement, but not with the scarring. Can put back up the question, or maybe I can put it up.
Sure.
Let me. Okay, so rosiglitazone is not pioglitazone. They're the same category, but there's no evidence for rosiglitazone. There's evidence of pioglitazone. So don't, if you want to use one of the agents in a patient who's diabetic and has fat in the liver, you're going to draw for pioglitazone and not rosiglitazone. And then, of course, resmetirom is the only FDA-approved drug, so definitely. That's the only one, so that's the answer. That one can improve fibrosis in patients who have F2 or F3 and can reverse it. So it's the drug to use. And of course, high fructose corn syrup is only going to make it worse. So you want to avoid that, take it out of the diet in patients who have fatty liver or steatosis. Okay, so that's the end of my presentation. And if you have any questions, I think we can take them.
Excellent, excellent. Thank you so much, Doc. I think in the interest of time, until Dr. Gordon gets here, question. First is FIB4 useful in older patients over 60 years of age?
FIB4 useful in older patients over 50?
6. 1, 2, 3, 4, 5, 6.
Yes, so FIB4 is useful in patients who are over 60. It's just that the older you get, obviously your age is going to now start to sway. So age alone is a variable which can change the reliability of the results in terms of deciding whether the patients end up in which category. And most patients will end up being intermediate because their age is pushing them over. So we still use it, but in terms of reliability, we know that it's more likely they're going to end up with a FibroScan or some other kind of non-invasive test to decide what their real risk is. But definitely, once age is a factor, as an independent factor, it may sway things, but it's still useful.
Okay. Are ALGP1 agonists available in Jamaica?
Well, everything is available in Jamaica. Question is, should it be here? Everyone knows. I don't think there's anybody who is going to fool themselves to say that, listen, patient, you don't know a patient who's on it. Somebody's going to be on it, and the reality is that somebody has written it for them. Sometimes they get it overseas as well, but I don't know that there's a distributor, and I don't know that the ministry has registered the product for use here. You know,
Fair enough.
that's essentially what it is.
Fair enough. In an obese diabetic and diagnosed with MASLD and failed lifestyle modifications, could one use either GLP-1 RAs or SLG2 inhibitors, such as, and there's a name here I can't pronounce, forgive me, or even as combinations if there is no contradictions? What is
Okay.
your opinion on the costly resmetirom or resmetirom? Will insurance pay for it?
Okay, so resmetirom story definitely is costly, yes, no doubt. It's not available locally, first of all. It will be eventually, I'm sure. And like all things, eventually the cost will come down, but it's going to be very expensive for a long time because they're going to want to recover their development costs and whatnot. Whether it's useful, certainly. Whether insurance will cover it locally, well, debatable because there's not enough information currently to allow insurance companies to cover even FibroScan, for example, because there's not enough sensitivity. And this is helping, these fora and so on are helping to sensitize those who pay in terms of the significance of the condition. But again, in the spectrum of everything, there are other things that you can spend on to try and improve the patient's outcome before you reach resmetirom. In the patient who has severe obesity and you want to use either the SGLT2 inhibitors or the GLP-1 agonists, definitely from a liver standpoint, as I said, the SGLT2 inhibitors would not be something that you want to be adding or achieving a significant liver outcome. So no, I wouldn't combine them for that reason. If the person is failing the usual lifestyle therapy changes and they're obese and have diabetes, it's likely that they may qualify for metabolic surgery. And I think we need to try and access that more. I mean, if we did have the GLP-1 agonist available, then yes, definitely that would be something that you could put patients on. The likelihood of achieving significant weight loss and improving liver profile is very high, comparable almost to metabolic surgery. So that would be one thing to do before surgery. But surgery is something that needs to be looked at, and that's something that, you know, the benefit is clear on.
I have a question here from Dr. Buckland. Which lab does FIB4?
Any lab. So remember now, this FIB4 is, you can just use your exact profile. So you don't need to pull anything. It's not a specific, lab or test. It's just a calculated score. So when you send your patients off for their exact profile, you already got back your platelets, you already got back your AST, you already got back your ALT, you already know what the patient's age is. So you just plug them into the formula, it will give you the score. So the lab is you're not gonna write FIB4 on the lab form. You're just gonna write that you want exact profile, or you just want those, if you just want those things, you just want ALT, AST, and a CBC. And when you get results back, you just look at them, plug it in to your phone or your computer, your whatever website. It will tell you what the FIB4 is, and it will usually interpret it for you as well if you don't remember the 1.3. It normally tells you what to do when you get the score back. So any lab that's reliable, of course, because,
Thank you so much. While we're speaking about FIB4, could you remind us of the formula or where they could find to put the formula in?
Yeah, Google is good. So if you remember the name FIB4, put FIB4 into Google. But if you wanted a specific app, MDCalc, MDCalc is a good app for lots of different medical stuff that needs to be calculated. It's in there, so as a single app. But once you just Google FIB4, it will show you it will direct you to a number of different calculating websites, and you just put it in, whether it's on your phone or the computer, and just remember FIB4.
Thank you so much. Can we use PIO in patients that do not have type 2 diabetes?
You can use it. It's not going to necessarily cause hypoglycemia because of the way it works, but there are other things you can also use, because this is off-label now, so you're not using it, as a recommended trial-backed, industry-backed anything. This is based on the way it acts and the incidental, as it were, data showing that there's improvement in liver scores. But if you have had a patient who is not diabetic and you wanted to put them on pioglitazone because of the liver, as I said, that's not where I'd start. You wouldn't start there. There are other things you should encourage them to do before putting them on the agent. There are other agents you can use as well. We didn't speak about things like milk thistle and what things not coming to mind now, but there's some other coffee can be beneficial as well to the liver in patients who have fatty liver or steatosis as well. There are other agents that you can use. Coffee, yes, high consumption of caffeine has been shown to be beneficial in a number of patients who have chronic liver disease, not just steatosis, but even in patients who have steatosis, consumption has been shown to reduce the progression towards either steatohepatitis or even fibrosis. The outcomes are there. There's
not the frozen Starbucks coffee.
Right. So to say you can't necessarily predict, because it's meta-analyses that were done which showed propensity towards benefit, and once you do that, you're talking about different types of coffee, different concentration of caffeine and all kinds of different things.
Right.
It's just a general recommendation. There's another agent.
Fair enough.
But I wouldn't use the initial pioglitazone just like that. You can though, but I wouldn't just draw for it. There are other.
Do you recommend regular screening with serum ALT in obese children for muscle D? And if so, what age would you recommend it and what BMI?
Okay, so transaminases, AST, ALT, as you look through, notice I didn't speak about them at all because they don't correlate very well with basically anything. I mean, it shows you that there's definite inflammation. So if they're high, then there's hepatitis, of which there are a number of causes, of which steatosis or steatohepatitis is just one. So it definitely tells you there's inflammation, but they can still have inflammation and have normal transaminases, and they could still have steatosis or just regular fat with normal transaminases. So they're not sensitive enough to be used as screening to decide if the patient has liver disease. Once they're high, definitely something is going on. You need to figure out what it is. But to say that you're going to just do LFTs on someone who's obese, 15 years old, for example, to check for a liver issue, no, it would tell you necessarily potentially the severity of the liver issue, but as a start, whether you can ignore the person, especially for steatosis, no, you want to do your if they have metabolic risk profiles, so they're obese, young, you want to do an ultrasound. If you want to look for steatosis, but you want to do your FIB4, and then that will tell you what their risk profile is and how far you want to go in investigating them if they don't have anything else, any other reason to, but LFTs will only, they are part of the assessment overall, but as a screening tool, they're not good.
Thank you so much. I see Dr. Miller's confirming that there's a Play Store app for FIB4. So if you go to the Play Store, you can just search for that there. And I see some persons confirming with the caffeine as well that there have been other, Dr. Sharma from Harvard, for instance, has mentioned in 2016 the effect of caffeine. I see a couple of questions here that I'll merge about the side effect of weight gain from PIO. Is it that it's considered minimal? Is this why it's something that can be used in weight loss for muscle D?
Yes, so as Professor Boyne spoke about earlier, it's a redistribution of fat that we're looking at, and depending on where, so the fat becomes more obvious in some places where it wasn't obvious before, but metabolically it becomes more inert, so you're not getting the deleterious effects on the liver. So you're improving in that standpoint, but at the end of the day, you know, it still looks like the person is putting on weight, and so patients will complain of weight gain because it's looking more obvious. It's not on deep inside; it's more surface. But metabolically, there's improvement. So, you know, that's kind of where that's going.
Thank you for your presentation. Excellent. Dr. Mills is a question or the statement here. Is there any role for statin therapy in MASLD/MASH?
All right. So simple, broad answer, no, not really. If the person already has dyslipidemia and you're targeting the dyslipidemia, then yes, definitely statin plays a role there. But as from an anti-inflammatory standpoint, to see if that component has any effect on the steatohepatitis, it hasn't been shown to be beneficial in that way. Outside of that, you can still use statins. As was discussed earlier, the effect on the liver in terms of hepatitis is minimal. It's been overstated in the past. So once there's an indication to use a statin, you can. Bear in mind that you can still get transaminitis from it. And we have patients who have had to pull back. But as a broad rule, you're not going to draw for a statin to try and treat steatohepatitis or steatosis in particular, because the mechanisms are different and what you're trying to achieve, the statin is not going to help you with that.
Dr. Mills, Prof. Boyne, thank you so much. I hand back over to Dr. Gordon, who will moderate the rest of the session. Thank you.
Thank you very much, Sam. Very interesting, informative presentation from both presenters. But to give the formal vote of thanks, we're going to ask Ms. Altovia Clark from Ravis Pharma to give the formal vote of thanks. Ms. Altovia.
Good evening, everyone.
Good evening.
We have come to the end of a very illuminating and very informative session. But before we go, I would just like to take a few minutes just to show gratitude. First, I'd like to first and foremost thank God for making this webinar a resounding success. Without him, this would not have been possible at all. On behalf of the entire Ravis Pharma team, it is my privilege to express our heartfelt gratitude and to acknowledge the contributions of all those who worked hard to make this webinar possible. You know, this did not happen overnight. It took weeks of planning. So we are very grateful to everyone who played a role in making this possible. I express our sincere gratitude to our highly esteemed speakers, Professor Michael Boyne and Dr. Matt Mills, who spared time from their busy schedules to grace this occasion. Professor Boyne, your presentation has enhanced our understanding of MASLD, the forgotten complication of diabetes. Your deep and intellectual way of imparting knowledge has added to the glory of this event. Thank you so much for your explanation of the pathophysiology and treatment options, which will guide doctors' understanding of this condition for the best therapeutic outcome for their patients. Professor Boyne, we have no words to offer gratitude to your valuable presence here. Thank you so much. Dr. Mike Mills, thank you so much for providing us with an excellent coverage of the management and diagnosis of MASLD. Your presentation has enlightened our minds and have shown us a new path for effectively diagnosing and treating MASLD. I am sure everyone here tonight appreciates all the information presented, and it's our hope that going forward, this condition will not be taken lightly, but effectively manage one patient at a time. Dr. Mills, thank you so much. Also, a big thanks to Dr. Donald Gordon, President of the AGPJ, for moderating this webinar, and the entire AGPJ team for working closely with us to make this event a possibility. We could not have done this without your contributions, and we simply cannot express our gratitude. Also, thanks to Samuel Heron, our IT administrator, for working behind the scenes to ensure a smooth webinar. My heart goes out to our respected audience for accepting our invitation and being present here with us this evening. Without your presence, we could not have accomplished what we had hoped. I hope that you all leave here tonight with a better understanding of the disease and the importance of early diagnosis and treatment. In conclusion, we are deeply grateful to everyone who contributed to making this event an unforgettable one. Thank you, each and every one of you, for your support and participation. Have a great rest of evening and good night.
Thank you,
Thank you.
Mr. Altovia, for such an excellent vote of thanks. And we thank the audience for staying with us throughout. So we had quite a large number of folks staying right through to the end. And we thank Ravis for collaborating with the AGPJ to put on this wonderful CME event. And we look forward to do some more CMEs with Ravis. Thank you very much.
Thank you very much. Congrats, everyone. Have a wonderful evening. Thank you, Ravis. Thank you again to the AGPJ. Have a wonderful evening. The survey will automatically come up on your device once you end the call, and it will also come as in an email from Zoom, from the AGPJ Zoom account tomorrow at around this time as well. Please stay safe. Please heed the weather warnings, stay dry, and we'll see you at the next one. Thank you very much.
Thank you, sir.